And now to begin the program, we welcome our Global Guideline Series moderators, Doctors Michael Conti, Joseph Mills, and John White. Doctors, the screen is yours.
Well, thank you, Pete. Good afternoon or evening to everyone. Happy Monday, and thank you all for joining us in this SVS webinar on translating guidelines into clinical practice, the Global Vascular Guideline on the management of chronic limb-threatening ischemia. This is the third webinar in this series in which we've been discussing the translation of the the Global Guidelines into clinical practice. And today's session is going to focus on anatomic staging and the use of the glass staging system in clinical practice and its relationship to revascularization outcomes. Let me start by first introducing my co-moderators, Doctors John White and Joe Mills.
Thanks, Mike. This is a session we're all looking forward to after the first two sessions. The first session was the medical treatment of a patient with newly diagnosed CLTI. And we had some great guidance provided by four internationally renowned speakers, including Dr. Sonia Anand, Josh Beckman, Mark Banaka, and John Gollage. What we learned from that session was, given our sample patient, they would recommend losartan for blood pressure control, as well as metformin for control of type 2 diabetes. Josh Beckman stressed the need for us as vascular specialists to begin a statin and not to fear high-dose statin if we believe that the patient has severe atherosclerosis. Mark Banaka pointed out that the best regimen for reducing the adverse events associated with CLTI would be to use a combination of low-dose Xarelto and aspirin. And finally, John Gollage, rather than just telling us we should counsel our patients about not smoking, presented a clear-cut and concrete routine using varenicline, as well as counseling to have a high incidence of success with smoking cessation. So it was a great session. We learned a great deal. Joe?
The second session included Alina Quiroga, Nobuyushi Azuma, and David Armstrong, and was Wi-Fi centric. And it focused on the importance of staging the limb to include an assessment of the foot and the hemodynamics of the foot, and also the importance of repetitive staging of the foot during therapy to potentially alter the course of treatment was discussed. We also described the use of Wi-Fi staging on the fly using the Wi-Fi stage calculator, which is available on the app, as well as contemporary data on the relationship between Wi-Fi staging and important clinical outcomes in patients with CLTI. Thank you.
Thanks, Joe. The management of patients with CLTI is obviously complex, and it's part of everyday vascular surgery practice. So it's our hope that together these three sessions are going to be helpful in expanding physicians' knowledge and improving the confidence and effectiveness with which you treat your patients with CLTI, and also employ the guidelines. In today's webinar, we're really going to focus on anatomic staging and how we do clinical decision-making about revascularization using anatomic staging. We'll review the rationale and the benefit of using a limb-based staging system, which is the glass, and how to use the online calculator. We'll review the available data linking the staging system to the outcomes of revascularization. And we'll discuss the potential impact of pedal artery disease, as well as drug-eluting devices as they relate to the current treatment of our patients with CLTI. Hopefully everybody has already downloaded the SVS Guidelines app from the App Store. If you haven't, please go ahead and do that now on your phone. You should note that there are three calculators in there related to the global guidelines. There's Wi-Fi for limb staging. There's a VQI mortality risk calculator in there as well to estimate perioperative mortality and long-term survival. And finally, there's the glass calculator in there, which we'll review in detail today for doing anatomic staging. In each of our webinars, we have focused on a single sample patient to guide us through the thinking process. and debate the issues that the guidelines have touched on. And today we'll review and extend the patient's case history. So our case history is a 72-year-old man who initially presented with a 6-week history of developing an ulcer on the second toe. He is a current 1 pack per day smoker with hypertension, recently diagnosed type 2 diabetes, and has really had rare medical care over the last 10 years. He initially had 1 block claudication, but he is not very active. He presented initially with an ulcer on his left, over his left second toe, which was present for approximately a month. And he had been treating it, or has been treating it, with local cleansing and daily dressings without evidence of healing. And recently it's worsened in appearance. He had a small prior MI, denies a history of stroke, no kidney disease, no drug allergies. His past medical history, he had a non-reversible ischemia result on a nuclear stress test. He has been started on aspirin, metformin, atorvastatin, losartan, and carvedilol to treat his hypertension, diabetes, and his PAD. Using the VQI CLTI risk calculator, which you are encouraged to do, you will find out that he is placed in the low risk group, which means his estimated perioperative mortality is less than 3%, and his estimated 2-year survival is greater than 70%. We can move forward. On his examination, his pertinent points here: his lower extremity pulses are 2+ at the femoral level bilaterally. His lower extremities looks typical for a patient with CLTI. The calves are hairless. The feet are slightly cool. The right great toe has previously been amputated, and that surgical site is well healed. The remaining toes on the right foot are pink and have no ischemic skin changes. The left second toe, where the ulcer originated, now shows dry gangrene, which has extended to the proximal phalanx. There are no other areas of actual or impending skin breakdown on the foot. So the appearance of the foot is on the left, and these are his non-invasive studies, which are shown on this slide. You can see that in particular on the left side, he has evidence of monophasic Doppler waveforms over the tibial arteries bilaterally, a flat waveform at the left first toe with a pressure of 0, an ABI of 0.32. So the Wi-Fi staging for this patient at this time of presentation would be a stage 4 based on a wound 2, severe ischemia grade 3, and dry gangrene with no evidence of cellulitis or foot infection 0. In our Wi-Fi scheme, we know this is a high-risk patient who's at increased risk for both short-term and mid-term limb loss. As we go through the thinking about anatomy and approaches to revascularization, we'll also consider the scenario of the same patient now presenting with more tissue loss in the foot, with the adjacent third toe and first toe involved, and the possibility of needing to do a transmetatarsal amputation, ultimately to resolve this person's CLTI. So next step up after performing his examination and non-invasive studies, a diagnostic angiogram is performed, and the key images will now be reviewed. We're going to walk through the sequence of angiographic imaging from this case, here beginning at the level of the groin, where you can see that there is disease in the proximal superficial femoral artery that's moderate, and then an occlusion is present in the upper third of the thigh. Moving down to the next station for a better look at the extent of this SFA disease, you can see that there's reconstitution in the mid-thigh, so that the total occlusion length is approximately 8 to 10 centimeters, and the total disease length of the SFA is between 15 and 20 centimeters. Popliteal artery has mild disease that's not hemodynamically significant. And then we can see that there's significant infrapopliteal disease with the dominant runoff vessel being the perineal artery. A better look at this below the knee disease reveals that the perineal artery has several areas of moderate to severe focal or segmental stenoses. Both the anterior tibial and the posterior tibial artery are occluded in the proximal portions of the calf. More distally, there is reconstitution from perineal branches of the posterior tibial artery and the dorsalis pedis at the ankle, with the posterior tibial and plantar being the dominant runoff into the foot.
Excuse me, Dr. Conti, before you continue, I just want to ask our attendees to please complete the pre-survey now, if you have not yet done so. We'll compile the results and compare them to a post-test that we will ask everyone to take at the conclusion of the webinar. This will be followed with a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into daily clinical practice. And all participants will receive the clinical practice guidelines, implementation tools consisting of guideline pocket guides, and a link to the app to ensure practicality in aiding participants in improving their clinical practice. Thank you.
Okay, with this case as a background, let's get started with thinking through how to approach a patient like this with CLTI and all the issues related to revascularization. We have a tremendous panel of speakers for our webinar tonight, and our first presentation is from Pat Garrity, Professor of Surgery and Radiology at Washington University in St. Louis. Dr. Garrity has been engaged in the development of outcomes measures and trial designs for the evaluation of devices in CLTI throughout his career. He's been a national or global primary investigator for multiple IDE trials of candidate PAD and CLTI devices. He is also the co-director of the multidisciplinary limb preservation program at Washington University in St. Louis, and clearly an expert in CLTI. Pat, thanks for joining us.
Welcome. I'm Pat Garrity. I'm co-director of the Multidisciplinary Limb Preservation Program at Washington University Medical School in St. Louis. Thank you for joining tonight's webinar. I'll be speaking about the global limb anatomic staging system. In particular, I'll be talking about the rationale, benefit, and use of the online calculator and angiographic data to calculate glass stage. If you haven't already, please download the free SBS IPG application to your cellular phone. This has several calculators included along with multiple practice guidelines, and open the glass calculator. I did want to address several of the acronyms found within the global vascular guidelines that are pertinent to this presentation. EBR stands for evidence-based revascularization, which is our approach to the clinical treatment of chronic limb-threatening ischemia. PLAN refers to the three-pronged assessment of patients for revascularization, where we consider patient risk, the severity of the limb disease, and the anatomic pattern of disease. Finally, GLASS refers to the global limb anatomic staging system, which considers the severity of disease throughout the entire path of revascularization. Within GLASS, we refer to two other options or acronyms, the first being TAP or target arterial path. This is the optimal arterial pathway to restore inline pulsatile flow to the foot, running from the groin all the way down to the foot. This can involve either the least diseased outflow vessel or angiosomal outflow vessel at the operator's discretion. The second is the concept of LVP or limb-based patency. This is the expected patency rate at 1 year for the entire revascularized treatment target arterial path from the groin to the ankle. The GLASS staging includes several key inputs and modifiers. There is an iridoiliac disease modifier, which is a simple two-stage modifier. For tonight's presentation, we will consider that the patient has no iridoiliac disease. The two main components of the GLASS are the femoral popliteal segment score and infrapopliteal segment score, and both of these are modified by disease length, CTO status, and severity of calcification. Finally, there's an inframolecular disease modifier. Let's consider the rationale for using GLASS. Our current endovascular data is largely focused on single segment interventional outcomes in highly selected patients, largely from IDE trials. This limits our capacity to predict real-world patency for endovascular intervention on multi-level chronic limb-threatening disease. And these are our usual everyday patients. In the Global Vascular Guidelines, the available endovascular patency and outcomes data was combined with the Delphi consensus of experts to predict limb-based patency for various scenarios, and these include the 3 GLASS stages. The GLASS stages 1 through 3 correlate to low, intermediate, and high complexity disease patterns. The data provided gives us estimated immediate technical success, as well as 1-year limb-based patency for endovascular intervention. It's important to emphasize that these are not static in nature. As better data becomes available, we anticipate that these guidelines will be revised and refined accordingly. Within the next year, we expect to see an excellent incoming amount of data from both the Basel II trial in the UK as well as the BEST CLI trial. Here are the 3 GLASS stages. To quickly summarize, GLASS stage 1, which is low complexity disease, has a predicted technical failure under 10% and a 1-year limb-based patency of greater than 70%. Stage 2, which is intermediate disease, has technical failure rates of less than 20%, limb-based patency of 50 to 70%. And 3, the most complex stage, has an estimated technical failure of endovascular intervention of greater than 20% and a 1-year limb-based patency of less than 50%. So let's begin to apply this to today's scenario. We have a 72-year-old male, dry gangrene in the left second toe. He's a former smoker, no active cardiac risk factors, a recent negative stress test, overall a low to normal risk patient for intervention. As we see here, he is a Wi-Fi stage 4 with a wound 2, ischemia 3, and foot infection 0. I'm now going to play the angiogram, which has been provided for tonight's exercise. As we look at these, we see that the SFA demonstrates a non-flush 10 centimeter chronic total occlusion. There's some minor disease of the popliteal artery. There's a tibioperitoneal trunk stenosis, significant stenosis of the proximal perineal artery, which is somewhat focal in nature, long segment chronic total occlusion of the posterior tibial artery with reconstitution at the ankle as the dominant runoff vessel. At this point, I'm going to open the online calculator and we will discuss how to proceed through the calculation. So on screen here, you will now see my iPhone screen, and we will calculate the initial target arterial path using the perineal artery outflow. As we click on the femoropopliteal segment, there is certainly a greater than 50% stenosis. The total disease length is 10 to 20 centimeters. There is a non-flush CTO of 10 to 20 centimeters present. Popliteal artery disease, I'm going to mark as stenosis less than 2 centimeters. Is there severe calcification? No. As we move down to the infrapopliteal segment, I will note that we will use the perineal for our preferred target arterial path. There is a significant stenosis in the proximal vessel, as you recall. I would state that is probably less than 3 centimeters in total, certainly less than 1/3 of the tap length. Actually, let's leave that at 3 centimeters, I think is more accurate. It is not an occlusion, so no, and it is not severely calcified. With that information, I'm going to hit the calculate button. Scroll down, here's our results. This gives us a GLASS stage of 2 intermediate complexity disease. I'm going to go back now and recalculate this using the posterior tibial outflow. So the femoropopliteal segment will not change, but I'm going to change our infrapopliteal preferred tap to the posterior tibial. Again, yes, there is hemodynamically significant stenosis. The disease length here is greater than 2/3 of the total arterial path length in the calf. There is a chronic total occlusion present. The CTO location is not at the origin. The CTO length is greater than 1/3 of that vessel. and there is not severe calcification. So as we recalculate, we will see that this yields a different answer. Now we're at a glass stage 3 if we choose to perform endovascular revascularization of that target arterial path going down the posterior tibial as the desired outflow vessel rather than the perineal artery. Having run through that online calculation, I think it's useful to consider a second clinical scenario. Here's the same patient with a greater burden of necrotic disease in the forefoot. This will require transmetatarsal amputation. In that setting, what will be our preferred target arterial path? Recall that the femoropopliteal segment analysis will not change. So we are looking at differences between the perineal tap outcomes versus posterior tibial tap outcomes. For the perineal tap, endovascular revascularization will yield a glass stage 2 with predicted patencies of 50 to 70% at 1 year. But posterior tibial endovascular revascularization would yield glass stage 3 with expected patency of less than 50%. If this patient had adequate venous conduit available for bypass, particularly in that second clinical scenario with more advanced necrosis that will require transmetatarsal amputation, this would strongly direct me to consider a femoral to posterior tibial artery bypass graft rather than initial endovascular recanalization. But certainly a topic for debate, and I look forward to comments from our other presenters tonight regarding this.
Thanks, Dr. Garrity. That was an outstanding presentation, and we're looking forward to the panel discussion on the choice of TAP and how to use the system. Our next presentation is by Dr. Mark Schermerhorn. Mark is the George Clues Professor of Surgery at Harvard Medical School. He's chief of the Division of Vascular and Endovascular Surgery at Beth Israel Deaconess Medical Center in Boston. And Mark has extensive clinical expertise across the range of vascular surgery, including the open and endovascular repair of aneurysms, advanced imaging, and has published extensively on outcomes of revascularization in CLTI. Mark's presentation is based on some of his own data and others. He'll review the current data linking glass staging to revascularization outcomes in patients with CLTI.
Hello, and thanks so much for the opportunity to participate in this webinar. I have no disclosures. The task system has been criticized for being overly complex and failing to account for multi-level disease. So the GLASS system was designed in part to correct this and allows us to identify disease states within both the femoropopliteal and the infrapopliteal segments that can be combined into a single staging system. We can assign a femoropopliteal grade from 0 to 4 and an infrapopliteal grade also from 0 to 4 and combine those to get an infrainguinal glass stage of 1 to 3. We can also add an inframalleolar modifier to reflect the state of the disease on the foot. Now, when this staging system was first designed, it was based on expert consensus rather than direct published data. So multiple publications have now been made validating this system, and we had one of the first. We reviewed our patients from 05 through 14 undergoing a first-time bypass or endovascular intervention. We excluded those who had prior procedures or where we couldn't identify the pre-procedure arteriogram. And our primary outcome was a composite of RAS, or reintervention, major amputation, and restenosis at 1 and 5 years. And then we also looked at endovascular technical failure at the time of the initial intervention. We had over 1,000 patients, almost 1,200 procedures. Stage 3 was the most common stage. Stage 1 was the least common. We had about half and half endovascular and open, and there were no differences in these groups in medical comorbidities, indication for the intervention, or the Wi-Fi score. But you can see that the more advanced disease was much more prevalent in the open patients rather than the endovascular group. Our average follow-up was 3 years. And if you look, you see that the overall survival was no different based on the stage with the 1 and 5 year survival rates given here. When we looked at RAS, or reintervention, amputation, or stenosis, we do see that they nicely splay out, showing the differences between glass stages 1, 2, and 3. Here are the adjusted hazard ratios with a 70% increase risk of RAS in stage 2 and more than a doubling in stage 3. When we look at the individual components, we see that stage 2 and 3 do have higher amputation rates, but it's not quite statistically significant, whereas reintervention and restenosis rates are significant with a 60 or 70% increase in stage 2 and a doubling or more with stage 3. When we compared outcomes of open versus endovascular, we saw a statistically significant improvement in RAS for bypass versus endovascular treatment in all 3 stages. And these were all statistically significant with the hazard ratios you see here, and we've adjusted for most of the things that we could that would potentially confound this. When we looked at immediate technical failure in the endovascular procedures, we found that glass also was associated with technical failure, more advanced disease, more failure. And we found that that was also the case for the individual components of infrapopliteal and femoral popliteal. Again, more advanced disease, more likely to have immediate technical failure. Now, there have been a couple of meta-analyses. This was the first, published this year. And this one included endovascular and open procedures for patients with limb threat. And they looked at amputation-free survival, limb salvage, major adverse limb events, overall survival, immediate technical failure, and then limb-based patency at 1 and 5 years. There were 8 studies, 1 randomized trial. This was the Basel I trial, and then 7 retrospective analyses. This was ours here. There were over 2,200 patients, almost 2,500 limbs. Again, class 3, by far the most common. 870 bypasses, over 1,600 endovascular treatments. For the entire analysis, it was 2/3 endo, 1/3 bypass, but several of the studies did not include bypass patients. And when you limit it to those including bypass, they got the exact same thing that we had, nearly 50-50. The average follow-up in these studies varied from 10 to 49 months. When looking at outcomes, amputation-free survival at 1 and 5 years did not vary significantly between the different glass stages, nor did overall survival, shown here. However, limb salvage was different, as was major adverse limb events, and also immediate technical failure and limb-based patency, but only when combining both glass 1 and 2 in comparison with glass 3. So here are the hazard ratios showing those again for amputation-free survival, no difference. Overall survival, no difference. However, limb salvage was statistically worse for stage 3, as was major adverse limb events. Immediate technical failure, no difference between glass 1 and 2, but glass 3 was worse than 2, and glass 3 was worse than 1 or 2 with the relative risks here. And then limb-based patency, again, worse in stage 3 versus 1 and 2 with the hazard ratio here. When analyzed separately in the bypass group, no differences were seen in amputation-free survival, limb salvage, male, or overall survival. Whereas in the endovascular group, there were significant differences in amputation-free survival, limb salvage, and male as you compared glass 3 with 1 and 2. No differences, once again, in overall survival. Now, when comparing bypass against endovascular treatment, looking at major adverse limb events, this was our study. We did see a significant difference, but in Basel I, no difference. And in the combined group, no statistically significant difference. You can see the different hazard ratios here and the overall hazard and the confidence interval. On the other hand, however, for glass 2 and glass 3, there were significant differences. There was agreement between ours and Basel, and the overall group definitely shows that there is an advantage to bypass surgery over endovascular treatment. The hazard ratios are over here, both statistically significant. Obviously, this is limited by the number of patients, by selection bias and confounding within our analysis, and also limitations of the treatment options available during Basel I differences in disease patterns around the world, et cetera. And obviously more data are needed. There are some more data that are already coming out. This is a second meta-analysis now available online. Some more recent studies. This one's focused on endovascular only with 1,800 patients, almost 2,000 limbs. And very similar findings. Immediate technical failure was associated with class 3, either with or without calcification. Amputation was associated with the class 3, and limb-based patency, not quite statistically significant, but close, again, favoring the earlier glass stages 1 and 2 over 3. Now, lots of other papers are coming out, and we'll probably have more meta-analyses in the future. But looking through all these papers, I suspect that if they were added to the existing meta-analyses, they would not change the conclusions at this point. So I think we can conclude from these data that glass is not associated with overall survival. However, the glass stage, in particular 3 versus 1 or 2, does have significant associations in endovascular treated patients, but not bypass treated patients, with the more advanced glass stage being associated with worse amputation-free survival, immediate technical failure, limb salvage, and major adverse limb events. And in the more advanced glass stages, we do see a significant advantage of bypass surgery over endovascular therapy. Therefore, I would conclude that the current glass staging system can help us to select bypass versus endovascular therapy as an initial treatment strategy in our patients with limb threat. And if you're asking, well, how can I put this into practice with my patients? Well, you just go to your phone, open up your SVS Guidelines app, scroll down to the calculator section, find the glass system for CLTI, click on that, and this allows you to input data for both the femoral popliteal segment and the infrapopliteal segment. Once you fill that all in, you press calculate, and that gives you your femoral popliteal grade, your infrapopliteal grade, and then your glass stage. And then if you go back and up and click on the guide to the calculator, it'll pull up this, which shows what the expert consensus estimates were for immediate treatment failure and 1-year limb-based patency based on that, which are somewhat similar to what we found in our analyses and the meta-analyses, in particular, stage 3 versus 1 or 2. And so I found this to be quite helpful in helping me select therapy for my patients, and I think that you'll all find it useful too. I highly recommend this app. There's lots more good stuff on there, and you'll use it almost every day. Thanks again, and I really look forward to the discussion.
Thanks a lot, Dr. Schermerhorn. And as a reminder to all, some people are using the Q&A. Please use the Q&A button on your bottom of your screen. You can submit your questions to the panelists at any time, and we'll be having a extensive discussion session at the end of all the presentations with all of our presenters. Next up, let's hear from Dr. Leanne O'Banion from the University of California, San Francisco at Fresno. Leanne is an assistant clinical professor of surgery at UCSF Fresno, where she's been a faculty member since 2017. She's an associate editor for the JVS CIT journal. She serves on the executive council of the Western Vascular Society, and her clinical research has focused on limb salvage as well as ERAS pathways in patients needing vascular amputations. Leanne will join us now with a presentation on pedal artery disease and its impact on the outcomes of revascularization. Dr. O'Banion.
Good evening. I'm going to be talking about pedal artery disease and the potential impact on outcomes of revascularization and current tools. These are my disclosures. Due to advancement in medical management strategies for our CLTI patients, they are not only living longer, but sustaining acceptable quality of life. Therefore, limb salvage in this subset of patients is becoming a more attractive option. Pedal atherosclerosis, as you can see here, has skyrocketed in PubMed searches, meaning we are desperately searching for options to treat these end-stage vascular patients. We do know that pedal artery disease is probably under-recognized, with most interventionalists focusing on the larger, more proximal vessels. In one angiographic study of 1,600 patients treated for CLTI, in which 85% of the cohort was diabetic and a third had some degree of renal insufficiency, over 70% of the patients had some degree of below the ankle atherosclerosis evidence on diagnostic angiograms. The pedal glass modifier will inevitably become more important as we continue to understand the pathophysiology and revascularization strategies of inframalleolar disease. The same authors also identified that patients with more pedal atherosclerotic burden had significantly slower rates of wound healing, required more podiatric reinterventions, and had an overall higher rate of major amputation. So what's currently in our toolbox? Well, unfortunately, we are still limited to optimization of inflow, plain angioplasty, and inframalleolar bypass. Newer technologies such as limb flow and traditional open deep venous arterialization may be viable options, but long-term high-powered data is lacking, and these tools require strong multidisciplinary limb salvage approaches, as these patients are quite complex. And while there are some non-surgical options and experimental options, these are limited to the true end-stage patients with no options left, and the data is sparse. So below the ankle, how do we assess perfusion and how do we decide when to treat? Let's revisit our patient for the evening. This is a 72-year-old male diabetic smoker who presented with second tail gangrene, who is a community ambulator and had a current EF of 55%, which placed him at a low risk of 2-year survival of over 89%, and he was optimized on medical therapy. He has Wi-Fi stage 4 disease, placing him at high risk for major amputation without urgent revascularization. But the story doesn't end here, as now we have more tools to assess and risk stratify this patient based on the degree of inframalleolar disease. Medial arterial calcification occurs independently of atherosclerosis and is strongly associated with aging, diabetes, and chronic kidney disease. It tends to affect the arteries diffusely, appearing as a linear contiguous rail track pattern of calcification on plain angiography. In patients with diabetes, MAC has been associated with infrapopliteal artery disease, tissue loss, and major amputation. It's also associated with a high prevalence of occlusive tibial and pedal arch disease, leading to blood flow restriction into the forefoot. Here, the single institution retrospective review of 250 patients identified that male sex, diabetes, end-stage renal disease, and glass pedal score were independently associated with a higher MAC score. And in turn, this higher MAC score was significantly associated with risk of major amputation. This highlights that MAC can be a standardized measure of inframalleolar disease burden to utilize in conjunction with Wi-Fi and help stratify patients and determine optimal treatment strategies. Furthermore, the same authors examined 306 patients stratified by endovascular therapy versus open bypass. And in the endovascular therapy group, lower PMAC score was significantly associated with improved Wi-Fi grade post-revascularization. And likewise, the only factor independently associated with failure to improve was higher PMAC. In the bypass group, Wi-Fi ischemia grade was improved in 76% of patients, irrespective of PMAC score. And thus they concluded that high PMAC score is associated with poor hemodynamic response to endoluminal revascularization, which in turn translated into increased risk of major amputation. You can see on plain X-ray shown here that our patient has severe medial arterial calcification in all assessment points shown in the yellow by the yellow arrows, giving him a MAC score of 5. Now that we've established this patient's MAC score, let's move on to the principles of GLASS as they pertain to inframalleolar disease. Reiterating that the target arterial pathway is defined as the primary infrapopliteal artery target for achieving effective revascularization in this specific patient. It may or may not be angiosomal based and should be defined by the treating vascular specialist at the time of angiography. The pedal modifier, which does not affect the overall GLASS stage, has recently come into light as a critical component of the staging system and may provide valuable insight into patient prognosis and help optimize treatment strategies. You can see here I've outlined the 3 different pedal modifiers: P0, which is an intact pedal arch, P1, which is an absent or diseased pedal arch, and P2, which is no target artery crossing into the ankle. Looking at the pedal arteriography on our patient, you can see that while the target artery, the posterior tibial in this case, crosses the ankle, on delayed imaging there is absence of an intact arch and the distal DP is highly diseased. So this would score the patient as a P1 modifier. There have been recent publications which suggest that open revascularization may be superior to endovascular therapy in advanced glass stages. But what's the data on patients with inframalleolar or pedal disease, and how should we be treating these advanced CLTI patients? Here's a study which examined 254 perimalleolar open distal bypasses and stratified them by pedal glass modifier. Primary patency in P2 cases was significantly lower than in P0 cases. And while P2 cases had the poorest rates of wound healing, the authors actually found acceptable rates of wound healing at 78% at 1 year and no difference in overall limb salvage rates. Interestingly, there was no significant difference in secondary patency, which may be attributed to the diligent duplex ultrasound surveillance afforded to these patients with a low threshold to reintervene. The study also demonstrated that wound healing occurred in most patients, regardless of the pedal arch patency, highlighting that adequate blood supply via open bypass to an inframalleolar target can have acceptable wound healing without direct revascularization. However, the data may not be as strong for endovascular interventions. Here's one study, like the one before, which examined glass pedal modifier and its association with outcomes on 1,226 patients treated with endovascular therapy for chronic limb-threatening ischemia. And overall, pedal glass modifier grade 2, non-ambulatory status, hemodialysis, an EF of less than 50%, and Wi-Fi stage 4 were significantly associated with non-healing. But the big kicker here is that on additional multivariate analysis, modifier grade 2 was the only significant factor associated with major adverse limb events or death, further highlighting that the glass pedal modifier may hold more significance as it pertains to endovascular interventions. Here's another study which examined 585 patients with isolated below-the-knee disease undergoing endovascular revascularization. And what they found was that with severe inframalleolar disease alone, or in combination with severe infrapopliteal disease, afforded significantly higher rates of both technical and perioperative failure compared to non-severe cases, further highlighting the need for improved endovascular techniques in this difficult space. In this last study, in 137 patients with CLTI who underwent endovascular therapy, compared those who had successful revascularization into an intact pedal arch versus those without. And what they found was significant decrease in amputation-free survival and limb salvage in those without an intact pedal arch. And thus what they concluded is that direct flow into an intact pedal arch as it pertains to endovascular interventions is likely essential. And so in conclusion, below the ankle PAD is very common in diabetics and patients with end-stage renal disease. Higher PMAC and pedal glass scores portend a poor outcome for wound healing and are a major risk factor for limb loss. Open bypass appears to be favored in severe inframalleolar disease, and current pedal endovascular therapies are limited to PTA with marginal improvement in perfusion and modest improvement in clinical outcomes. And some studies have found that intact pedal arch may be essential. And so is pedal arch angioplasty the future? So what do we need? Well, we need alternative interventions for below the ankle disease. We need better assessment of perfusion, including spatial assessment of the localized wound environment. Thank you for your time.
Thanks, Dr. O'Banion, for putting a complex topic together very nicely, I'm sure, and I already see there's going to be lots of questions about this. Our final presenter on the panelists is Dr. Peter Schneider. Peter is professor of surgery here at UCSF. He was a founding member and chief of the Division of Vascular Surgery at Kaiser in Hawaii for many years, where he developed a diabetic limb treatment program and has overseen the development of endovascular interventions over more than 2 decades. Peter has authored a textbook on endovascular skills that many of us have used over the years, first published a number of years back and now in its 4th edition. He's also founded 2 medical device companies and is an advisor to many, many others for his expertise in the treatment of advanced PAD and CLTI. So really no one better to make this presentation to us on discussing the current evidence on the risks and benefits of drug elution in CLTI, Peter Schneider.
Good evening, this is Peter Schneider, and I'm going to talk about the risks and benefits of drug-eluting devices in CLTI. I'd like to thank Drs. Conti, Mills, and White for inviting me to this very interesting SVS webinar. These are my disclosures, including some companies that are developing or have developed drug-coated devices. So this is what the big picture looks like for drug-eluting devices. In the FEMPOP segment and the BTK segment, there have been lots of programs for both drug-coated balloons and drug-eluting stents. In the FEMPOP segment, most success has been with paclitaxel for both balloons and stents, several of which are approved. In the BTK segment, it's less clear. There have been failed efforts now in both paclitaxel and substantial new development of limus delivering compounds, which I'll discuss. Keep in mind that the drug-eluting stent paradigm and the drug-coated balloon paradigm are quite different. And if you look at the studies of drug-eluting stents, you see a very short lesion length, typically less than 5 centimeters. For drug-coated balloons, much longer segments are tackled. And we'll have to see over time which of these works best. But my sense is that the types of disease that we really need help with BTK is in the long, slow flow arteries with diffuse disease, maybe occlusions. And my sense is a full metal jacket probably won't be very helpful there. So here are paclitaxel drug-coated balloons below the knee, which have been compared with PTA. These are 3 essentially failed studies, none of which will go forward. And these are 2 additional paclitaxel drug-coated balloons, one from Medtronic, which has completed a first-in-human, one from EcoArt or Ecotech from China, which has completed a randomized controlled trial of 120 subjects with a significant difference at 6 months. These 2 may go forward. The Illuminate BTK program is on hold, and Ranger BTK is unknown at this time. How about mortality? Well, this has mostly been assessed with paclitaxel in the FEMPOP segment. This is the SAFE PAD trial, showing no difference in drug versus non-drug, including in the patients that had critical limb ischemia that had drug versus non-drug. Here's the Voyager PAD randomized controlled trial, 4,300 plus patients, almost a third of whom received drug delivery, and showing no difference, DCB versus PTA, DES versus BMS, and overall mortality, no difference. The SWEDE-PAD study, we're all familiar with this trial showing no difference, but this trial had the added benefit, in addition to being an RCT, it also broke out CLTI versus claudication, showing no difference in mortality. What about amputation risk with paclitaxel? This is a more recent concern. This is borne out by the concept that each of these drug-coated balloons will shed particulate. This has been shown in many preclinical studies. And in this summary level meta-analysis of 21 RCTs, it did show an increase in amputation risk versus plain balloons or stents. Now, of note, 19 RCTs that had no amputation events were excluded. CLTI and claudication were lumped together, making it a little bit difficult to know what this means for CLTI patients. And in addition, many of the devices in the study are not commercially available. The largest weight in the study was Impact Deep, which of course is not a commercially available device. Now, this is an interesting study from the Barmer Insurance database, and it's helpful because it isolates it to patients who had BTK treatments only. And this demonstrated actually slightly better survival in patients who received paclitaxel. And it also looked at mortality separately, cardiovascular event or death, and amputation or death, showing no evidence of increased risk for paclitaxel. This is a study of critical limb ischemia patients from Case Western. Almost 1,000 patients, 58% received paclitaxel delivering devices with actually slightly better survival and slightly better freedom from amputation in those who received paclitaxel. This is the Safe PAD as database I just showed you about mortality, now looking back to see about amputation, showing no evidence of increased risk of amputation. Likewise, the Voyager, which we already talked about, showing no increase in male. Now, there are some advantages to sirolimus in that it is cytostatic rather than cytotoxic. The challenge with sirolimus is tissue absorption and tissue retention, which tends to be more challenging than with paclitaxel. Nevertheless, there are several sirolimus compounds which are in development. This is a Med-Alliance BTK-DCB, which is being studied under an IDE in the United States. The first patient was entered into its BTK trial in June of 2022, just recently. And this is the solution SFA results from outside the United States, but showing definitely an acceptable late lumen loss in comparison to other studies. Concept Medical has a sirolimus delivering balloon that uses a phospholipid carrier to help the sirolimus absorb into the cells, and this has been studied in an early stage and has not yet reached an IDE, but you can see that the clinical trial plan for BTK disease is quite robust. Likewise, Surmodics has a sirolimus-coated DCB. First in human has been completed. The results will be presented at VEITH in 2022. What about paclitaxel drug-eluting stents? Well, this is the PADDY trial, which has 5-year results, which you can see here. This is a coronary paclitaxel balloon expandable DES, demonstrating out to 5 years at least some improvement in amputation and amputation-free survival. That has not gone forward in an IDE trial in the United States, so therefore is not approved. There have been other studies, the Yukon, Destiny, and the Achilles trials, looking at drug-eluting versus non-drug-eluting devices, all showing a significant improvement. But keep in mind that this type of study with primarily balloon expandable coronary stents, whether they're paclitaxel, everolimus, or sirolimus, these show excellent patency, 70 to 85% at 1 year. However, the lesion length is quite short. As I mentioned up front, most of these are under 35 millimeters, and one goes a little over 45 millimeters. So likewise, the Saval trial, we had high hopes for this because this is a self-expanding stent, so therefore should not be so crushable as a balloon expandable drug-eluting stent. And this, of course, has a polymer layer which helps the drug remain adherent to it, has excellent results in the FemPop segment, and when used in the BTK arteries under the Saval trial, there was no evidence of benefit. You can see primary patency for DES 68% at 1 year, and for PTA 76%. Keep in mind, mean lesion length was 6.8 centimeters, so on the shorter side. Tissue loss was present in less than half of the patients enrolled in the study. There are also some bioabsorbable vascular scaffolds under study. This is an ongoing IDE that has recently extended its endpoint from 6-month to 12-month. I heard recently that the trial was enrolled, and this data should be coming forward as soon as the follow-up period has extended. But there's been lots of excellent data prior to that randomized trial, and this is from Ramon Varco and his group, showing a 71% patency at 4 years with this device. And there are a couple of other bioabsorbable vascular scaffolds which are in development, R3 Vascular and Riva Medical, both in an early stage. So let's go back to tonight's case example. This patient had femoral popliteal disease that was quite extensive. I would say anybody with grade 2 or higher on the glass scale in the FemPop segment could potentially strongly benefit from the enhanced patency of drug administration, whether by DCB or DES. There's no evidence of increased mortality. I remain unconvinced about the amputation risk, but this is still under evaluation. BTK disease, if you look at the perineal target artery path, this is focal disease where balloon angioplasty does fairly well. The posterior tibial target artery path, however, a long segment occlusion, this could strongly benefit from a drug delivery program that hopefully one day is successful in the US. So in conclusion, most of the data on drug delivery is in patients with claudication. The enhanced patency continues to be an important unmet need, both in the FEMPOP segment and the BTK segment, but it's really the BTK segment where we have a lack of solutions. Paclitaxel, DCB, and DES are approved for FEMPOP, but safety, especially amputation risk, is still under surveillance, and both paclitaxel and sirolimus formulations are under investigation for BTK applications. Thank you very much, and I really appreciate being able to participate with you.
All right, well, thanks again to all of those outstanding presenters this evening. I'm now asking everyone, including the co-moderators, to join us, turn on your cameras and mics for the roundtable discussion. We've had a bunch of questions coming in on Q&A, but I'm gonna kick us off a little bit in the discussion. Let me start with Pat. The case that we talked about is, not uncommon in practice, where you have two choices of a target artery path that you're trying to decide upon based on what's best for the patient. That's one side, but also maybe what's the easiest to treat is kind of on the other side. Can you maybe help frame sort of how, whether or not your selection of a target is different for endo versus bypass? How, when, and why? Is that true, or should you just pick one target artery and either way?
I think this case really provides a nice example of exactly how that gets different. Really harvesting a couple more inches of saphenous conduit, as long as you have good conduit to get to that posterior tibial, is a relatively simple thing. And actually the exposure is probably easier than the mid-perineal artery from a surgical standpoint. And that gets you right down onto the plantar aspect of the foot. So from a surgical side, I think the two approaches are essentially equivalent in a surgeon's hands, whereas the endovascular one not only has just a little more work associated with it, but I think a lesser expectation of patency. I think it all flows together logically in the sense that if you have a patient with resting pain or very minor tissue loss, that perhaps that's straightforward, particularly if they're at higher risk, going for that straightforward perineal revascularization is likely going to be enough. But as you move into that more advanced tissue burden loss, then getting that direct plantar flow from that posterior tibial, at least to my mind, as I'm stratifying that, becomes the preferred approach.
Now, Pete, you sort of, and several of the questions also came up around thinking about a hybrid approach for that patient, which is an interesting approach, I think often very relevant. We don't have a lot of data around those, but you mentioned that if you were going to treat the FEMPOP segment, you would probably use drug elution. What are your thoughts about, if that's what you're thinking you might be doing? Is there any risk to doing a retrograde access to that posterior tibial if the patient has a vein and your bailout is a bypass, or how do you sort of weigh that out?
Yeah, that's a really good question. Pedal access, retrograde pedal access, of course, has really taken off. It's really become part of our armamentarium. And also a lot of lesions that we considered either uncrossable or high chance of not getting across in the past, now we can get across them. I think that there is probably some risk, but I think it's small, that we could potentially be losing runoff. I myself only use a distal access for crossing and do everything I can to avoid treating that way, which would cause for enlargement of the access at the pedal artery. I don't think, there is some data to suggest it's super safe, but I honestly don't believe it's super safe. Nothing is that we do in these patients. And my sense is that we should do it with caution and not just assume and do it routinely. and that we should continue to monitor it like we monitor so many things for safety and continue to improve our technique.
I'll open it up to any other thoughts from the panel around the different approaches to that patient. I think it provides a lot of different ways to skin the cat, particularly if the patient is or isn't a good risk patient or does or doesn't have a vein. Mark, you have some thoughts about the staging of that? It's just doing it all at once.
I do, and I want to first agree completely with Peter that I don't believe that I do pedal access, but I don't believe that it's a complete freebie, and so I try not to access an artery anywhere near where I would be plugging in my bypass. So if they've got some artery up higher that I can use for access, then I will go ahead and do that for retrograde access. I think the key thing with retrograde access, it lets us cross the lesion, but it doesn't change the characteristics of the lesion. It's still however long it is, however length of occlusion. And so it'll improve our treatment failure, but it's not going to improve our durability necessarily. Yeah, and then in terms of, for this patient, certainly in scenario 2, I would want to do a bypass with good vein down to the ankle to the PT, and then do the TMA. I would, if I had really good vein and this patient was really healthy, I would consider it also in the first scenario. It's a pretty long segment of disease. That gangrene is right down to the base of the toe. It's going to be a pretty big wedge that's going to have to come out of there, and it's still going to have some trouble healing that. So, but that being said, I don't think there's too much wrong with initial attempt at an endovascular approach. Again, I do believe that an initial endo approach does sometimes burn bridges. I think several people have shown data about that. But I think in this case, it would likely be safe. I think that posterior tibial target would be preserved. And so I do think that it would be something you could back into. And there's several options for a hybrid approach as well, with an endo treatment for the SFA or a prosthetic bypass for the SFA if you were short on vein. So you could still do a completely surgical approach with then vein from below the knee down to the ankle.
Yeah, I was thinking, so for the first patient, depending on their other risk profile, endo would be tempting, because I think that's just going to be a toe amputation. And if you get the SFA and perineal open, that's probably going to be enough. The second patient, I wonder if anybody else thinks the same way, but that worries me because you're going to have to do a TMA. So I'd be really reluctant to do that unless I had documented markedly improved perfusion just from the SFA and perineal. So I'd be wanting to get the PT open. So then in my mind, what I would do up front is risk stratify the patient and look at whether they have vein or not. So if I know they have poor vein or the patient's high risk, that's the person I would consider retrograde access. I think it's pretty safe. And like Pete, we either just use the wire only or at the most put a 4-French sheath in. So it's only used for crossing. It's not used, we almost never treat from the bottom. We get the wire through and then do all our treatment from the top. So having said that, if you're really careful with pedal access, you usually don't burn bridges, but I'd be reluctant in a lower risk patient who had good vein, I'd be reluctant to start trying to treat that PT endo because it's almost a full segment total occlusion, right? So just crossing it gets you off the technical barrier of failure immediately. But at least in my experience, those are all down by 3 to 6 months. And so if your TMA is not healed, you're in trouble. So I kind of take all that. I do pedal access if I've already decided up front that they're going to have a prosthetic or some less optimal open surgical bypass. That's just me.
Leanne, I think everyone is feeling that pedal disease is growing, with the increasing sort of metabolic disease in the population, and at some point it probably needs to be formally incorporated into this staging system once we know more about how it affects the outcomes. Just to start out though, can you just describe how you get really good imaging of the ankle and foot? I think you can't really deal with the disease until you really have shown it properly. So how do you bring it out well, especially in people who have proximal occlusions? And then what kind of tools do you use for perfusion assessment, either in the OR or out?
Thanks, Dr. Conti. So, I mean, I think, a lot of times we get patients referred that don't even have a foot shot. And so I think getting the foot shot is key to start with. And then I think as we learn more about the pedal arch, getting a really good both AP and kind of oblique view of the foot is key to fully understanding and getting that good view of both the AT and the DP, and then the medial and lateral plantar branches of the posterior tibial, and understanding where the gaps are and what needs to be revascularized. Because I think it does play a role, and I think some of the data has shown that we've shown tonight that if you're going to do a bypass to the posterior tibial, maybe you don't need an intact pedal arch. But if you're going to go after this patient with a sole endovascular approach, maybe revascularizing that pedal arch is going to be necessary. And I think that we need to continue to explore that in our research. And then in terms of perfusion measurement, currently at our hospital, we don't have the luxury of pedal acceleration time and intraoperative, techs doing those advanced duplex imaging. And then I think, FlowMet is a up and coming technology that can be of benefit. So I think there's a lot of things on the horizon, but all of those things actually do require you having either a multidisciplinary team that can help you in the OR with that, and or having the technology available at your hospital. Currently, we're using, just toe pressures post-intervention to kind of assess perfusion. If it's endovascular, I tend to get it within the first 24 hours or before they leave the hospital. Open bypasses, I'll tend to wait a little bit longer because I think just the hemodynamic response is different.
Thanks. We got a really good question in the Q&A. Maybe I'll start with Peter, and it's about the role for multi-tibial vessel revascularization. What's the current data on that? What do we see downstream, and how do we apply any of this logic, to whether or not multiple vessels should be revascularized?
Yeah, well, I'll just say I don't know what the right answer is, but I have a feeling that that this is a paradigm that's currently shifting. We started out with our bypass concepts around getting one good target revascularized, but I think with endo you can go after multiple tibials, and so because the hemodynamic result of endovascular treatment is frequently less, let's say, less encouraging than we'd like it to be, a lot of people have gone toward opening more tibials, more than one, for example. So I'll just say right now that seems to be where people are going, but I will also say there's no data to support it, or at least there's data to support both approaches. The challenge is almost all of it's retrospective. So in the case where you said, well, geez, we did all these with two vessels and there was no benefit. Well, yeah, those are also the patients with the larger wounds that crossed angiosomes, and the typical scenario of a Rutherford 6 or a Wi-Fi stage 4, it's rare if they don't cross angiosomes, let alone the 3s. So people are more apt to want to open more tibials. So without knowing what the right answer, it could be that we'll have that at some point. But at this point, what I would say, what I like to do, just my rule of thumb, open the easiest one first. And if the easiest one really is easy and you have another one that you think is actually going to give a better or more appropriate hemodynamic response to the area in question, I'd go after that one. And actually, this case is a nice example. You got the perineal, and very often when you have two different target artery paths to consider, like this case, it involves the perineal, and our inability to predict, looking at the perineal collaterals, what kind of response you're going to get from an endovascular treatment.
Yeah. If I can jump in to echo Peter's point, all the IDE trials, we've painstakingly written the protocol so that people can do multi-vessel revascularization. And yet I think at best we see about 10%. And these are obviously a group of very aggressive percutaneous interventionalists in these trials. And so I think if by and large interventionalists get one excellent outflow vessel to the foot, particularly if it crosses the ankle, they're done usually. But I think in that setting where you're getting perineal or a non-angiosomal vessel, there is that kind of minority share of chasing. And I think nothing wrong with it, but it just really isn't certainly I wouldn't say it's a majority of cases, even in the
And it would be so amazing if we had what Leanne just asked for, which is immediate feedback, a way to assess hemodynamics on the table that gave you a sense of, okay, am I in the green zone now or not? And since we don't have that, we're very often looking at this complex anatomic morphology without really knowing what physiologic result it will have.
Excuse me, everyone, but before you continue the discussion, I do want to alert our attendees that we will go ahead now and launch the post-event test. As with the pre-test, attendees will need to scroll through and answer all 18 questions, and you'll only be able to click the submit button after you answer all of the questions. We'll compile the results as soon as all of the attendees have completed the test. This will also be followed with a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into daily clinical practice. Thank you.
So let me just ask, jump in here. So if we start with this patient that actually began with a second PIP joint ulcer, if as Leanne showed, you got an X-ray and the pedal vessels were heavily calcified, including the digitals, what would you use for your assessment for intervention or following that patient? I mean, would toe indices be of any value? Toe pressures be of any value to you? What are you going to do?
I personally still use the toe pressure because usually the pedal calcification stops at the end of the forefoot, and the digital arteries are typically spared, but not always. So we combine that with a forefoot PVR, and we look at both. And in the patients who've already had a TMA, then we follow the forefoot PVR. It's a lot more subjective rather than objective, but you know, it's the best that we have, or at least the best that we have in our hands in our institution.
Yeah, I agree. And, you know, looking at the waveforms also matters. We have some early experience with pedal acceleration time that looks promising, but it does require technician training. I don't find TCPO2s super reliable unless they are really bad or really excellent, and there's a large gray zone in the middle which isn't super predictive.
Yeah, we had some experience with Indocine and green, and I originally thought that would help us during a procedure. So you, like the example Peter gave, you revascularize the perineal, but I found that in some of those patients you don't get the maximal improvement in perfusion for a few days. It just doesn't open up immediately, and I'm excited about PAT, but I'm a little skeptical that that's going to be able to give us an on-the-table answer either. I don't think all the collaterals are predictable immediately after intervention. I think that sometimes it takes time. They're the so-called choke vessels, and some of the vessels that you don't see initially that show up when you restudy the patient. So I think PAT is exciting, and it does give you an option for people with no toes, or people that have ways of, you know, TMA that's not healing, or a TMA that you did something to. How do you reassess the perfusion at 3 months when it seems to have stalled? You know, that would be helpful there, I think. But I haven't found anything totally useful intra-op. I don't have a lot of experience with that 2D perfusion from Philips. I don't know if anybody's used that, but I think the same problem is going to be there. The patients are cold sometimes they're under anesthesia, and sometimes the collaterals. We've all seen a profundoplasty alone, right, for rest pain, and the patient's foot doesn't warm up for a day or two completely. I think the same thing happens when you do indirect revascularization and you're waiting for flow to come back through collaterals.
I wanted to ask a question from the group about just, you know, mindset when you start the angiogram, because I think if you're going to use the system, the question is, you know, what's your mindset going into the case, because it's obviously very convenient to just start treating. So, you know, Mark, you mentioned, you know, the data, but how do you incorporate it into your workflow, into your clinical decision-making with the patient? You know, most commonly, I mean, there's lots of different scenarios, but let's just take a patient like this one who's got a lot at stake and a reasonable risk candidate. So before you do the angiogram, I mean, how does the workflow allow you to make these decisions with the patient?
I think, you know, a lot of times we can sort of predict the severity of the disease just based on what we're looking at down on the foot and their clinical history. So, we usually have some idea of what we're going to see with that angio. So we get surprised, certainly on a regular basis, but most of the time we have a good idea. I think the other thing in terms of not being surprised and having all the data that we didn't really talk about is the utility of the duplex of the vein before you go to the angio suite. That was something that I congratulate the BEST trial folks for putting that together and making that a mandatory part, because we didn't always do that. And even now, we still aren't perfect at it, but because we do ultrasound guided access, if we haven't had a pre-op vein mapping, then we'll just do it right there on the table at the time. So when we're thinking about, should we proceed with this endo or should we hold off and do a bypass, we always know what we have for vein. Which I think is really crucial.
I have to say I'm fairly liberal with CTA depending on the referral pattern of the patient as well. Sometimes it works to integrate that in. In that case, I'll sometimes even take a pass on the ultrasound vein screening or just augment it as necessary at the bedside because I can see the entire conduit on the CTA as well. So I find that handy. It gives you a little more info about the kind of degree of bulky calcification in terms of femoral aneuplorectomy and gives you the aortoiliac segment really nicely too.
We have a question about angiosomes and, how to incorporate angiosomes when selecting the target artery path, sort of in which cases do you pay more attention to that? Anybody who would like to take that one on?
I mean, I think it depends on the amount of tissue loss. I think I would approach it. I think someone alluded to it earlier that the case number 1, I would approach maybe a little bit differently than case number 2, where the patient needs a TMA. And then, I'd push more for getting inline flow to the posterior tibial, where in the first case, you might get an inline flow via the perineal and see what happens if it's just a toe amp or a small ulcer that you need to heal, where there's not as much stake, if you don't pick correctly.
For me, I look at the angiogram and the angiosomes. I look at as what's supplying that angiosome at the time that I'm doing the angiogram, and it's not always the way it was when they were born because of collaterals that develop. And so I think angiosomes change over time, and I just look at that angiogram and figure out which one of those vessels down near the ankle has the best flow out to wherever the lesion is, regardless of whether it followed the textbook pictures from the injections. So I just base it at the time there. What's going to get me the best flow to the lesion?
Yeah, I think the angiosome data, pretty much most people would agree. If you can revascularize the angiosome in question, the wound healing is more rapid, but there doesn't seem to be a huge influence on ultimate amputation rate. I also think, like Leanne said, that that first patient with the smaller wound, there is some evidence to back that up. So John Baptiste Rico looked at Wi-Fi stage versus angiosome in patients who had perineal revascularization. They were mostly bypass, and the Wi-Fi stage had more influence on success than the direct or indirect revascularization, which means that if you have a bigger wound up front, it's probably it hurts you more than what angiosome you pick.
But Peter,
so I'm sorry, go ahead.
I was just say, Peter, we have a question about whether or not the use of stents in target arteries could potentially impact bypass. You have any anecdotal?
Yeah, I mean, sure. It's always something that we think about, that we want to preserve our target. Our targets for bypass. Really, it's the same story about pedal access, that we want to preserve our targets. Having said that, I think with regards to any kind of endovascular planning, it's making sure you maintain your plan B, plan C, your contingencies, and I think doing what you can to avoid stenting anywhere around a place where you'd either clamp or sew makes a lot of sense. The other thing just to consider is that, I mean, my sense is that through the 2000s and the early teens, we stented way too much. And that there's no evidence that the infrainguinal bed is a friendly bed for any kind of, full metal scaffold, et cetera. We've routinely gotten bad results from that. So, I think going forward, aggressive vessel prep followed by avoidance of scaffold whenever you can is probably going to be where we end up with most endovascular therapies. That's just my opinion. I don't have any data to back it up, except for the cycle of violence that occurs once in-stent restenosis starts.
Any concerns about paclitaxel and wound healing in a diabetic foot ulcer patient, Pat? Or Pat, how about you on that one?
Yeah, as Peter mentioned, a lot of it goes downstream. There wasn't differences between arms in the studies that we've run looking at the wound healing rates. They're always incomplete, I think, due to the contribution of neuropathy. There's always kind of a baseline muddle of ongoing and new neuropathic wounds during the course of these trials, but we really didn't pull out differences in wound healing between arms in any of these studies that I'm aware of. But yeah, I think as we embark on the sirolimus era, everyone's taking a little bit of a sigh of relief, thinking that maybe we have something that's a little less toxic in terms of what gets down into the foot capillaries or in the wound beds. There was one question, Mike, there, an interesting question in the Q&A. One of the attendees asked the question, doesn't higher glass stage also mean there's less likely to be a good distal target for bypass? And so I think it really raised the question of, even though we kind of speak about our preferences for these, class 3 in very broad terms, that in each case, the individual nature of what you have is going to dictate that. If you have a heavily calcified distal reconstitution segment that's just simply not sewable, of course, you're going to want to try endovascular over that. So I think it doesn't necessarily mean that there's not a good distal target. It means that the distance and complexity of disease between your femoral inflow and that final target is probably longer and more significant. But there are other factors like the quality of the target segment that may influence your final choice, certainly.
Right. I mean, and Mark's data basically shows that, lots of patients with glass stage 3 can get bypass successfully, but we know that the factors that determine success for bypass are different. They are, at least if not more dependent on the quality of the conduit than the disease that you're going beyond. So I wouldn't be deterred too much by how long the disease is, but you need a good target to plug into, a good conduit and some outflow, of course, to support a bypass. So they are different though, and that sort of gets to the notion of understanding where your patient is. If they have a good vein, are they a patient who's a candidate for a distal bypass before you start down the path of, several hours of recanalization. And I guess I'm looking at a question.
There's been a couple questions on atherectomy, so maybe we can go around the panel. What role does atherectomy play, and when do you use it, and when is it part of vessel prep? Do you frequently use it, rarely use it, or selectively use it?
Not an atherectomy user. Very rarely.
I'm also very rare.
Patrick, when do you consider using it, or when do you have to use it?
Peter, you first, go ahead.
Sure, yeah. I think for me to have to say selective. I think, and we know that the theories around this cover the entire spectrum from very little to a lot of atherectomy use. The challenge with atherectomy use is that pretty much all the trials that we have are all approval trials without good comparative data. And the second thing is that I believe embolization probably occurs more often than is clearly stated or studied in the literature. And so just like with drug-coated devices, if we're shedding harmful particulate, we need to really understand that, because you don't want to be making, a nicer target lesion while you're actually making the point of the operation worse, of, salvaging the foot. So I use it selectively. I think there are cases though where, throughout my career, I would just say, like, the glass classification didn't exist before, but we never would have gone after more disease morphology this severe. And the disease is moving distally, it's becoming more calcified, and the amount of calcium that I'm seeing, I never saw 20 years ago, somebody who was essentially calcified from the puncture site down to the big toe. And so this is what we're dealing with. So the idea that we're just going to throw atherectomy out doesn't make any sense. We just need to learn how to use it, who to apply it to and how to do it safely. That's my 2 cents.
Yeah, for me, I'm a really infrequent, verging on rare user of it for, osteal, heavily calcified lesion or something really eccentric that I don't think I'm otherwise going to get good compliance. I have more and more been leaning towards the use of intravascular lithotripsy, which comes under the atherectomy code, even though it's not frankly excising it. But I think I'm hopeful that that will achieve some of the vessel compliance goals that I'm looking for without the embolization penalty that has always made me wary of atherectomy. But yeah, as Peter mentioned, when these devices come on market without good kind of comparative IDE data, the sad fact is that we never get a quality, randomized construct therever after. So we kind of fly blind from that point onwards in terms of true outcomes.
I think I'm not seeing a lot of other new questions in here, so we might be reaching a time to wrap up. I think we have a wrap-up slide or two, Pete. So again, I want to thank all of our presenters tonight. Outstanding panel, Dr. Garrity, Schermerhorn, O'Banion, Schneider, and my co-moderators, John White, and Joe Mills. We will be sending a final survey in 60 days. And within 2 weeks, all 3 of the webinars in this series will be available via the SVS on the web. And you will be able to get certificates of completion if you attended the 3 sessions. There are, of course, the 4 pocket guides that are available through the SVS. And a couple of other things to point out of note for many of you who I'm sure are actively engaged in limb salvage and trying to improve your practice and your data set. The BEST CLTI trial will be reporting out its primary results in 1 month from today at the American Heart Association Scientific Sessions. Doctors Alec Farb and Matt Menard will be presenting the primary results. So there'll be a lot of data to follow and discussion after that. And at the VAM meeting coming up next June, there'll be a postgraduate course focused on CLTI, at which a lot of that data and others I'm sure will be presented, debated, and discussed. So it's actually we're entering a window of unprecedented amount of new information to help guide our practice. I think these tools are meant to be just that. They're meant to be tools. They're meant to be adjusted and become flexible. And as data accumulates, I think guidelines have to be revised. And I think that's what the SVS will be planning to do over time. So thanks again for joining us tonight. We appreciate all of your time. And again, thank you to all the panelists and moderators.